please?
Yes, sir. I just dropped the message on chat box.
Okay.
Ma'am, please unmute yourself.
Good evening, everyone. I, Ganavi YP, on behalf of the Indian Thyroid Society, welcome you to another session of the Wednesday Special Thyroid Clinics. So before we start the session, let us briefly go through the journey and the activities of the Indian Thyroid Society. Indian Thyroid Society was established and registered in 2003. It is a national body of healthcare professionals with special interest in thyroid disorders. It includes endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons. ITS is a member of the Asia-Oceania Thyroid Association, that is the IOTA. It has currently nearly 2,000 members. So the executive committee includes the founder president, Professor R.V. Jaikumar sir, and the present president, Professor Sarita Bajaj ma'am. Also past president, Professor Rajesh Ratput sir, secretary, Dr. Arun Menon sir, and treasurer, Dr. Miniji Pillai ma'am, are all members of the executive committee. So Dr. Himagirish K. Rao sir, who is the vice president, Dr. Pramila Kalra madam, scientific committee coordinator, and joint secretary, Dr. Sujay Gur sir, are all members of the executive committee. Dr. Shashank Joshi sir, Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir, Dr. Mohammad Riaz, Dr. Sushil Gupta sir, Dr. Ashraf Jani sir are all members of the executive committee. So the aims of the Indian Thyroid Society is to organize academic activities for the healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, to encourage publication in our flagship journal, that is the Thyroid Research in Practice, and to have state-of-the-art publications, to award fellowship of the society, and to encourage membership of the society. So the ongoing activities of the Indian Thyroid Society include the CMEs, the updates, the symposia, and the conferences. So also the thyroid clinics, which were initially held weekly, fortnightly, and now being held monthly, include journal clubs, case conversations, monologue, dialogue, panel discussion, meet the professor session, quiz, workshop, as well as CPCs. So the programs conducted by the Indian Thyroid Society include the Thyroid Awareness Week, which is celebrated between May 22nd to May 28th, the World Thyroid Day, which is celebrated on 25th, and the Thyroid Awareness Month is celebrated annually in the month of January. So the research activities by the Indian Thyroid Society includes the provision of annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. The research grants are available and the details of this research grants can be accessed through the website, that is the www.indianthyroidsociety.in. So regarding the Indian Thyroid Society journal, that is the Thyroid Research and Practice, which is published twice a year in print and online, it has a quick turnaround time with the electronic copies which are available ahead of print. So the fellowship awarded by the Indian Thyroid Society is basically for the ITS members who have expertise and experience in the field of thyroidology. So this will be decided and selected by an expert panel. The eligible members will be conferred the Fellow of the Indian Thyroid Society. So the publications of the Indian Thyroid Society include the ITS Clinical Manual of Thyroid Disorders, first edition by R.V. Jaikumar sir. The other guidelines by the Indian Thyroid Society include the thyroid dysfunction in pregnancy, the management of thyroid dysfunction during pregnancy, hypothyroidism and diabetes, management of subclinical hypothyroidism, guidelines for the management of dyslipidemia and thyroid dysfunction, also guidelines for the management of depression and thyroid dysfunction. So the upcoming publications include the ITS Clinical Textbook of Thyroid Disorders, the chief editors being Dr. Sarita Bajaj Madam and Dr. Rajesh Ratput sir. So the upcoming guidelines which will be published in the due course of this year will be the management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, and management of thyroid carcinoma. So the website of the Indian Thyroid Society can be accessed through the following link, that is the indianthyroidsociety.in, and the contents included in this website are the link to the guidelines, access to ITS journals, a record of all the academic events, and also online membership portal is available. So the membership of the Indian Thyroid Society is basically awarded to all the MCI registered modern medical practitioners in India. So there are two types. They are eligible to become life members. Two types of life membership are available. So the full-time life membership and the associate life membership, and the amount is about 2,950 rupees. So full-time life membership is awarded for the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, whereas associate life membership is awarded to all the other registered medical practitioners. So the applications are invited online on the ITS website, and it can be accessed through the link, that is the indianthyroidsociety.in. So now moving on to our session for tonight, that is the Wednesday special thyroid clinics. So Asmita, can you please display the slides? Yeah. So the Indian Thyroid Society, the webinar is being conducted under the leadership of our distinguished conveners, Professor Sarita Bajaj Madam, who is presently the president of ITS, Dr. Pramila Kalra Madam, scientific chair of the ITS, Dr. Minichi Pillai Ma'am, who is the treasurer of ITS, Dr. Arun Menon sir, who is the secretary of ITS. So for today's program, we have Dr. Vikrant Katnati sir as the chairperson, and we have a panel discussion for which Dr. Rajat Gupta sir is the moderator. So the panelists for today's panel discussion on differentiated thyroid cancer, that is a team approach, will be Dr. Amaya Joshi sir, Dr. Gaurav Malhotra sir, and Dr. Ritesh Agarwal sir. This will be followed by quiz by Dr. Srinath Shetty sir, and then we have the monologue on medullary carcinoma of thyroid by Dr. M.J. Paul sir. And finally, the quiz winners will be announced.
So, ma'am, we begin with the quiz, dummy quiz.
Yes. So for the ease of participation for the quiz participants, so we have displayed the quiz participation rules. So to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in quiz, and all 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So we shall move ahead with the first session. So before we start, can we have okay, so we have the dummy questions. Okay, so the first dummy question is in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. The second dummy question, that is how many oceans are there? Option A, 8, option B, 5, option C, 6, and option C, 7. So hopefully all the participants could log in their answers. So moving on to today's session. So we have our distinguished and esteemed chairperson for today's session, Dr. Vikrant Katnati sir. So sir is presently the professor and head of the Department of Endocrinology, JNMC Belgaum. Sir has been awarded Dr. Prabhakar Kore Gold Medal in Medicine for securing the highest marks in postgraduate medicine exam. Sir has also been awarded the Best Outgoing Postgraduate in Medicine from JNMC Belgaum in 2009. Sir has received the first prize in national level medical quiz held at Epicon 2009 at Greater Noida, and he was also awarded the first prize in zonal undergraduate pediatric quiz conducted by IAP at Gulbarga in 2004. Sir has also received second prize in the case report podium presentation at Assam Endocrine Society Conference in 2014. Sir is member of Endocrine Society of India and also the American Association of Clinical Endocrinologists. So over to you, sir, to introduce the moderator.
You are mute.
Okay. Thank you, ma'am. Good evening, everyone. It's a pleasure to welcome you all to the Indian Thyroid Society webinar. So today we have a panel discussion on differentiated thyroid carcinoma, a team approach. Dr. Ameya, Dr. Gaurav, and Dr. Ritesh will be discussing that. So before we go ahead, I'll be introducing our distinguished moderator for this session, Dr. Rajat Gupta. Dr. Rajat Gupta sir is a senior consultant in endocrinology at Alchemist Hospital, Panchkula. He's done his DM from AIMS. He's recipient of A.B. Gandhi Award in 2010 for the best research on methodology in vitamin D. And he's been a speaker and chairperson in various national and international conferences. Over to you, Dr. Rajat sir, to just carry on to bring forward the panel discussion and to introduce the speakers for the panel discussion. Thank you.
Thank you, sir. Thank you, Dr. Sarita Bajaj ma'am, for inviting me for this discussion. So I will introduce the speakers or the panelists. We have Dr. Amiya Joshi, Dr. Gaurav, and Dr. Ritesh with us. Dr. Amiya is Director Diabetes and Endocrine Clinics in Mumbai. He is consultant in charge endocrinology at Bhaktivedanta Hospital and Research Institute and Karuna Hospital, Mumbai. And he's been recipient of IDF and European Society of Endocrine Young Scholar Grant and Secretary Maharashtra Endocrine Society and Scientific Secretary ESICON 2019. Dr. Gaurav Malhotra sir is professor in Homi Bhabha National Institute and Bhabha Atomic Research Center, Mumbai, India. He has a lot of publications to his credit. Total number of publications in Index Journal is 54. And also last 5 years, he has published around 26 publications. Lot of awards and accolades to his credit. He has received award for American Medical Association has awarded 207 PRA Category 1 credits in last 5 years. And he has so many achievements as we can see here. Then we have with us Dr. Ritesh Agarwal. He's an endocrine surgeon working in Mumbai. He has 53 publications to his credit, and he has reached state level semi-final of MediMin Mind All India Talents Research Search Contest 2001. First prize in poster presentation at UPA SICON 2006. He's been awardee of Padma Shri Professor S. Vittal Best Paper Award in Indian Association of Endocrine Surgeons section at 71st Annual Conference of the Association of Surgeons of India in Kochi in Kerala 2011. And also he has been given the financial assistance for his conference in Singapore. So we are looking forward to all of you guests for discussing differentiated thyroid carcinoma. And we know this is the most common endocrine cancer. So many times we come across thyroid cancer, and we know it's a team approach starting from the ultrasonologist, then the pathologist making an appropriate diagnosis of differentiated thyroid carcinoma, then the surgeons, then nuclear physicist, and then endocrinologist. And so team approach is required for making this disease go smoothly. So I'll be putting few words and few questions and discussion points to all of us. May I start, ma'am? Dr. Sarita, ma'am?
Please go ahead.
Yeah, thank you.
Thank you.
So, yeah, ma'am, thank you. So I will be asking Dr. Amia first. Whenever we start, we see a patient presenting to us with the lump in the thyroid gland or the thyroid nodule. So what are the initial characteristic features on ultrasonography or after that FNA which guide us or which we suspect that this patient might be harboring something malignant or carcinomatous rather than the benign thyroid nodule. So this is a common thing because many times, most of the times, which is the most common presentation of thyroid carcinoma is the thyroid nodule.
Yeah. Am I audible, Dr. Rajat?
Yeah, please.
Yeah.
Yes, sir, you are audible.
Yeah. Just extending gratitudes to Indian Thyroid Society, Dr. Bajaj Madam, and Dr. Ritesh for conceptualizing this wonderful program. And it's pleasure to be here amongst two of the people, Dr. Gaurav and Dr. Ritesh, who have been together in the journey to learn quite a few things. So, Dr. Rajat, before even you think of doing an ultrasound, I think that the most important thing that matters is how do you sense the nodule clinically? I mean, same ultrasound features, same FNA in a 20-year and a 80-year, in a male and a female, will definitely tilt your decision the other way around. And I must tell you that after reviewing something which was written in IgM, me and Dr. Ritesh actually wrote to the editor that a simple marker like a size more than 4 centimeter on examination may just negate what you see on ultrasound or an FNAC. Having said that, I must tell you that this thyroid system has made ultrasound more objective. I mean, the kind of audience that is listening to this are fully aware about the thyroid system. I trust on that. And if you are not, insist that you get the nodule reported on a thyroid system, because it will definitely tell you whether you need to proceed with an FNA or not. If there is a multinodular disease, how many nodules to be FNA'd and what is to be excluded. And beyond thyroids, look for two more things. One is the vascularity. Definitely make sure that you don't ignore it, and look for the lymph nodes. And then comes the role of FNAC, which gives you a Bethesda rule. Now, to minimize a indeterminate sample, I think I learned that when I did an observership in ultrasound at Tata Memorial, that you must have an on-site cytologist. So those institutes who are not having a cytologist verifying the adequacy of FNAC, I think that is the first thing that they should get done, because that minimizes so much of effort. It sets you back by 3 months, mark my words. So if that is done, that definitely will help you improve and avoid inadequate sampling. Once you get an adequate sampling, I think it's a game between 2 and 5, 6 on one hand and 3 and 4 in the middle. And that's where the judgment and I would say equipoise decision making comes. I would invite Dr. Ritesh to share his comments on the same.
First of all, I would like to thank Dr. Sarita Bajaj and Indian Thyroid Society for inviting me here. Am I audible, please?
Yes,
Yeah,
sir.
yeah.
Yes, sir.
Thank you so much, ma'am. Good evening to everyone. And it is an honor for me to be in such an esteemed panel where Dr. Rajat, Dr. Amaya, and Dr. Gaurav, who are stalwarts in their field, are with me in the panel. So, Dr. Rajat has raised a very valid question that in the thyroid nodules, what to say on sonography. My practice is based on surgery only, and in all patients, I get ultrasound reports, very, very variable reports from different sonologists. But I always insist to get a thyroid grading to all the sonologists. Sometimes I have to talk to the sonologist. I have to tell them that please grade as per the thyroid grading. Dr. Amyas pointed very well. Any nodule, when the size has crossed more than 4 centimeters, or sometimes we have seen that when the collective size of the nodules has crossed more than 4 centimeters, then definitely the patient should prefer to opt for surgery, even if the FNAC and other features are benign. Other features on sonography which are very, very suspicious are irregular borders and solid nodules with vascularity. Hypoechogenicity is also another feature. And when there are microcalcifications, even if the nodule is solid, we can't ignore it. In the lymph nodes, there are two very classical features. One is cystic lymph node. Take my words, always remember this point. This is a very important clinical learning I have learned across the years, that any thyroid nodule with the presence of a cystic lymph node in the lateral neck has to be taken as a malignancy and metastasis unless proven otherwise. Until date, in my experience of more than a decade of operating on thyroid cancers, this is still 100% true that any cystic lymph node in the lateral neck with even a small nodule of more than hardly 1 millimeter, 2 millimeters nodule also has proven to be malignancy and metastasis in thyroid. So in lymph nodes, vascularity, cystic lymph nodes, hypoechogenicity, and the presence of microcalcifications. And when the lymph nodes are globular, most of the times lymph nodes are oval, but if we see the lymph nodes are globular, then they are more pointing towards malignancy.
Yeah, very, very valid point and the practical points to learn, sir. Any take on like I've seen, is my personal experience, as you said, the different ultrasoundologists, they give you different report, but the finding of the report, what you see, the descriptive finding and the direct grading which they do, sometimes that differs. So what I do in my clinical practice, I try to go and touch, get the discussion with the radiologist itself and what they feel, and the discussion point at that point also helps you to decide which nodule you need to do the FNA, because once you see solitary thyroid nodule, then it's the easier thing. But if you see multinodular goiter, then how many nodules do you want to do the FNA? The dominant nodule or the nodule which has got the more risk characteristics as per the ultrasonography. So this is what I wanted to discuss, that the nodule as solitary thyroid nodule or the nodule presenting in the background of Hashimoto thyroiditis or in the background of multinodular goiter, do you find any different risk in different settings, the STN versus the dominant nodule in the multinodular goiter? And also I would like to get the comment from Dr. Gaurav sir, that is there any role of scintigraphy in deciding which nodule we need to do FNA? If we do any scintigraphy, we find cold nodule or the hot nodule or the warm nodule for that matter, does that help us in deciding doing the FNA in a euthyroid multinodular goiter?
Thank you. Am I audible?
Yes.
Okay. See, scintigraphy at this juncture would usually not help. First, we do a TSH, and if TSH is suppressed, then first thing you do is scintigraphy. To know whether it is in a case of STN autonomic nodule, or in an MNG, we want to know whether these are the areas that we are dealing with toxic MNG. So that is a totally different scenario. Now coming to whether which nodule to be biopsied, many a times you would have multiple hypoechoic nodules in a multinodular goiter. So the nodules which are functioning less or which are having lesser pressure, radio pressure uptake, or cold nodules are the ones that have to be biopsied. This is one indication where, you know, in MNG this might help. Otherwise, MNG and its follow-up and everything is a completely your clinical diagnosis along with your sonography, good high resolution ultrasound, and guided FNA will yield things for you to proceed.
Yeah, thank you, sir. Yeah, Dr. Tesh, yes, you want to make a comment?
Yeah, because our patients are being commonly managed, Amaya Joshi, me, and Dr. Gaurav Malhotra. So we have seen so many patients where the big nodules had not proven to be malignant after surgery on histopathology, but very, very small nodules near 1 centimeter, less than 1 centimeter, or more than 1 centimeter in the same specimen were malignant along with multiple metastases. So it is very, very difficult to point out the exact nodule on sonography, because when there are multiple nodules, it is very difficult to hit that small nodule which is actually malignant. This is a fallacy on even the sonography guided FNAC, and we have to judge clinically all these cases.
Yeah,
Oh.
I think I'll just add few bullet points to what Dr. Ritesh has very, very clearly said. And the first point is take every nodule separately. A radiologist definitely will tell that, okay, these three are worth an FNA, and you FNA those three. It's not like I will choose only two most worst nodules out of 10. If
Yeah, as
three
many as
qualify,
you see.
yeah, I think that is the first thing. Second is in the presence of a background Hashimoto's,
Yeah.
it should be very clear that you are sampling a nodule and not poking a pseudo nodule.
Pseudonodule,
Because
right?
it's very common to for many radiologists to report. I mean, if you have your radiologist reporting, it's fine. But many times patients just come with a report, and the reports are invariably MNG, TSH of 100, and you can make out looking at the picture that it's just the different ecogenicity, patchy areas of hypoecogenicity that are just labeled as nodules, and they qualify higher on Thyroids to get an FNAC.
Right.
However, in a Hashimoto's, if you find that there is a marked increase in the size of a thyroid gland, and I think Dr. Ritesh will remember one diffuse enlarged patient in very early stages of practice. I had told that lady that, okay, your TSH is 100, gland is like this, but please meet my friend. And the marker that helped was LDH. So the LDH level was invariably elevated, and she turned out to be a thyroid lymphoma. And one also patient who had diffuse enlargement but turned out to be a differentiated thyroid cancer. So in Hashimoto's, if you look at practically, you have to look at a pseudonodular artifact. The nodular implications are somewhat similar, a little more tendency towards getting rare malignancies like lymphoma, but also some reports also say that the chances of malignancy are little high, 5% approximately higher in Hashimoto's. Now, any degree of calcification in Hashimoto's, except for a gross macro calcification, actually should be looked at as malignant till proven otherwise. I think Dr. Gaurav wanted to add something, sir. Yeah, Dr.
By error.
Yeah. One very important point for the endocrinologist, Hashimoto's is very common in their practice. And many times the patient is getting thyroxine. So always remember one thing. If a patient is getting thyroxine in the background of Hashimoto's, but if there's a nodular enlargement which is progressive, even if the patient is receiving thyroxine, should be very suspicious, because thyroxine suppresses TSH, and even if the nodule is enlarging, then that should be taken as a suspicious nodule, and we should opt more towards the surgery.
And also that signifies the importance of palpating thyroid gland on most of the visits, even if the patient is Hashimoto, even if the patient is on your regular follow-up. So at least looking at the neck very carefully and maybe palpating the thyroid gland probably takes 15 seconds of us only, just to have a good idea. If there's something separate nodule is palpable, so always do the ultrasonography. And if you have Hashimoto in background and any nodule which is not a pseudonodule, then probability the risk of being malignant is more than in otherwise thyroid gland. So
one more practical point I would just like to add, because we are discussing MNG, sorry for the interference, is that nowadays we have these radio frequency ablations available, and they work wonderfully in a clean, autonomously functioning thyroid nodule also, and clean solitary thyroid nodule also. But when you are putting an MNG through an ablation, be very careful. I have vetoed at least 2-3 times to the radiologist that, okay, you are not going to do this, and send them to Dr. Ritesh, and Dr. Ritesh has taken out a malignancy out of it. So I think, RF is going to be more and more used with these minimally invasive therapeutic modalities, but in an MNG, you should be very careful.
Yeah, please, Dr. Ritesh. Yeah.
Dr. Rajat, you asked also for the FNA and this is system. So we cannot rely, because there are so many ambiguity in the FNAC report from different pathologists, and as a private practitioner, we get so many different FNAC reports. So we have to read the FNAC report in full and then judge accordingly as per our clinical judgment which kind of nodule it is, suspicious or non-suspicious. Because many a times they write the features as suspicious, but final impression as hardly Bethesda grade 2.
Yeah. Recently, just today, I got a one patient. Basically, she had a thyroid nodule of around 4 centimeters, probably detected in 1 or 2 months' time. So the report from outside was Bethesda 2, and I repeat the FNA evaluation only. The FNAC same slide was reviewed by our pathologist. It turned out to be follicular neoplasm. So it turned out to be Bethesda 4. So now we move on to the real topic of today's discussion. So differentiated thyroid carcinoma, we know the most common is papillary and then the follicular, and then the Herschel cell and the poorly differentiated and medullary after that. So probably we'll be focusing mainly on the papillary and follicular thyroid carcinoma. So I would like to ask Dr. Amya, so in your practice, how do you how commonly you see papillary versus follicular? Which type of malignancy you see is more common? We know it's papillary otherwise, but what's your experience? And Dr. Ritesh also, please.
Yeah, I think I concur on that. That papillary is, I would say it's roughly 60-40 is what we see. And the only thing is, if you have to treat, more often than not, papillary has those ramifications that, okay, if I mean, if it is the subclassification that these variants are more likely to be. So when, I mean, you are dealing with some microcarcinoma or a smaller tumor for which you are in a dilemma, then maybe papillary can help you out in, I mean, further history, I mean, FNAC can help you out in what risk stratification, if at all you believe in that. I personally have been of the belief that papillary carcinoma is largely a multifocal disease, and I mean, you can be taken for a ride. So at least in a young, be bold enough to remove the whole gland. And obviously follicular has its own ramifications. Maybe Dr. Ritesh can add some.
So the micro papillary thyroid microcarcinoma, Dr. Ritesh, do you treat these patients differently from say T classification wise 1B or 2? 1A, do you treat differently from 1A or 2, 1B or 2? So micro versus more than 1 centimeter.
As a private practitioner, one thing very important is what the patient wants. I discuss with the patient everything in detail and explain them every pros and cons regarding the risk of recurrence as well as the need for thyroxine replacement. So whatever is their choice, accordingly I go. And believe me, most of the patients, when they come to know that, yeah, it is a cancer, even if it is very small, and if I said there will be no problem in the future, even if I remove the half thyroid, that is one lobe, but still they will not agree. They will always say that, doctor, please remove my whole thyroid, and then I am ready to take tablet. And it is the most common scenario in our clinical practice. Cancer is a word that even if it is associated with such a good prognostic cancer, even then patients opt for total thyroidectomy. So papillary microcancer in my practice is most commonly dealt as in the same manner as is the conventional cancers, and it is a total thyroidectomy and sometimes prophylactic lymph node dissection if lymph nodes are found during surgery. Here I would like to highlight two cases that I operated recently. One was a gentleman, approximately 61 years of age, presented with a large right lymph node mass. It was 6 centimeters plus mass, fully cystic. Some solid areas were there on the periphery. We did all the available imaging and testings, pointing that it is only a cyst, but there was a small thyroid nodule of hardly 1 or 2 millimeters on right side only. So we operated. We sent the specimen for frozen section biopsy, the lymph node mass. It turned out to be papillary thyroid cancer metastasis. We had taken the consent and we removed the thyroid also. In thyroid, in the same specimen, we find multifocal papillary, as Dr. Amya correctly pointed out. Papillary is usually multifocal, and all foci were 1 millimeters or 2 millimeters only. So it was a large lymph node metastasis with very small papillary microcarcinoma. Another specimen recently operated in young girl, 30 years of age, married but no children. She developed one lymph node swelling high up in the neck at level 2. FNAC and cell block was suggestive of metastasis from papillary cancer. We operated, total thyroidectomy and lymph node dissection was done. Only that lymph node was found to be malignant, and it was proven to be TTF1, TG, and HbME and PACSET all were positive. All markers of DTC were positive, but in thyroid there were small nodules, 1 millimeters and 2 millimeters, and all nodules were negative for malignancy. So papillary microcarcinoma can have varied manifestations and it can have metastasis. We cannot neglect papillary microcancer, saying that there will be no metastasis.
You mean to say that it's the preferred approach for most of the patient would be total thyroidectomy with central neck dissection. This is
I would like to say that first of all, we have to explain to the patient that, see, if we are doing total thyroidectomy, they have to take the thyroxine replacement lifelong. And if there's a single nodule, they can go ahead with lobectomy also. So it is the patient's choice. If patient is ready for active surveillance, then we can go ahead very well with lobectomy.
if you see one nodule on ultrasonologist on ultrasonography, and after surgery you find multiple foci of papillary CA in that lobe. So do you go for another side lobectomy, or sir, Dr. Gaurav, if you can give us? So is the radioiodine ablation would be a option there with one lobe removed, one lobe remaining there in a patient who has a proven papillary CA thyroid? I remember Dr. Bal with us in AIMS. He was a proponent of doing radioiodine ablation of the remaining lobe, and then he had some data also. So please highlight that information, sir.
It is there in the literature, though abbreviated guidelines in June 2022 of SNMI again have not clearly said as an indication that this is recommended. They have not also said that it is not recommended. It's kind of an investigation thing where they go for hemi-ablation. But as a practice point, no, guidelines is one thing, and even the GC is one thing. But as a practice point, I'm sure a surgeon would embark upon doing a hemi-ablation, in a scenario where surgery is not possible in the second, or maybe in the first there was a complication, rectoralaryngeal nerve was injured on one side. Then in that scenario, you probably don't want to risk a similar kind of injury on the other side, and one can embark upon hemi-ablation. It is not that, but it is not a kind of a standard of care as of now, and people are not following it in a common practice. In some institution, yes, Dr. Boulder is a strong proponent of this. There's no doubt.
So in that case, probably the right approach or the commoner approach would be to do the redo surgery and remove the remaining lobe, and then do the follow-up scan of lobe. Okay, so sir, again for you, sir, if what is the usual protocol we follow or your institute follow after the total thyroidectomy and the lymph node dissection? So do we ask the patient to be off thyroxine after surgery and come
there
after
are two
1 month?
ways. One aspect is again I'm telling you, see, recombinant TSH is an option where they money they have to spend on this. This is a costly will amount into nearly $1 lakh or maybe some more amount. So we can give 2 injections of recombinant TSH and then increase the TSH artificially, and that will ensure that we are able to do residual remnant ablation of whatever tissue is left in the thyroid bed. But more commonly, sometimes when patient says that I was, and especially those who need sometimes multiple treatment, when they say that we don't want hypothyroidism. But once I tell them the cost, that see, this is an option, but so they will say no, it is okay. We are okay with the hypothyroid state, and it is hardly anything. Even those with metastasis, I'm telling you, they will they're up for T3, so that we have to stop medication only for 15 days, and especially functioning metastasis. I will come to that later, but main thing is, in a standard practice scenario, after 3 weeks or so, after thyroid hormone withdrawal, this is a common thing that we do, and strictly iodide interference aspect. We cannot take more than 50 microgram of iodine per stable iodine per day. So we even tell the patients to avoid taking any bread, pizza, and all these which have got high iodine content, not to apply iodine to self or others, avoid saltwater fish, and red meat, and any other, and especially iodide contrast. If they have recently undergone CT, we have to wait for 3 weeks. Most of these are water soluble contrast. So all this preparation is a must, and fortunately, most of our surgeons are very well tuned to it. And even Dr. Tesh, when he sends his patient, we know that okay, no povidone iodine dressing has been done, and no stable iodine has gone from outside. And about 3 or 4 weeks after that, we are going to do a scan with a very low dose, 1 millicurie scan, 1 to 2 milligram of radioiodine, and we'll see whether the dose, and most of the time this would be yielding remnant tissue in the thyroid bed, which again has to be ablated. Either we go for remnant residual ablation if the disease is just localized to the neck, and this presumably is the benign tissue, or we go for adjuvant therapy when we are giving higher dose up to 150 millicurie with the presumption of tackling micrometastasis. And then the third common scenario is which is quite uncommon outside, but being a reference institute, we encounter metastatic disease. In those, we always give much higher dose than.
And after this higher dose of radioiodine ablation, do we ask the patient to be in hospital for 3-4 days, or we can send him home?
Of course, because see, patients get worried that why are we kept in isolation? So these things are, there is a lot of psychological ramification to that, and lot of counseling of patients is required beforehand. It should not come as a shock to them that why we have been isolated. So we tell them very clearly that it is not because of your condition or anything that you have been isolated. It is because you will be harboring so much radiation inside your body that you can harm other normal people. So their radiation level has to come down to a permissible level as per Atomic Energy Regulatory Board in India and respective regulatory boards in different countries. They have different level of this radiation which we monitor every day, based on which we discharge the patient from the ward after they achieve that particular. And most in our country right now, we can give 30 millicurie of radioiodine dose on OPD basis. So beyond 30 millicurie, most of the time after monitoring, we have to in isolation, and then all their materials have to be discarded as radioactive waste.
And even at their home, they have to be in isolation, even if they receive 30 millicurie. And those guidelines we usually tell them.
Beyond 30 millicurie. Below 30 millicurie, most of them it is OPD dose. We just monitor them and we ensure. Basically, it's the radioactive. When we are monitoring, the reading has to be less than 5 mR per hour. That is the concept. Earlier, it was more. We have to wait till 15 millicurie some years back. Then Atomic Energy Regulatory Board revised this, and even up to 5 millicurie, 5 mR per hour, we can discharge. That is equivalent to 30 millicurie.
Right, sir. Thank you, sir. Dr. Amya, so once we see the patient of papillary CA thyroid post-operative, then ablation being done. So what are the things you follow? You like to follow on follow-up side, like patient is, do we see thyroglobulin levels or thyroglobulin antibodies at the same time? The TSH, obviously, we follow the calcium and the ultrasonography. So what are the things you try to look into? And Dr. Desh, also, I would like to your opinion, like after surgery, do we label the patient at low risk of recurrence or intermediate or the high risk of recurrence? Because I have seen many patients coming to me after 4 or 5 years of, they do not have details of surgery with them, and sometimes it is not mentioned that what is the likely risk of recurrence, because that will also guide us in deciding how much TSH we need to keep, the level of TSH we need to keep for that particular patient. So I would like your comments, Dr. Ritesh and Dr. Amya, on the follow-up of the patient of differentiated thyroid carcinoma post-ablation.
Okay, I think Dr. Amya is not reachable, so I will reply first. See, follow-up of any thyroid cancer is very important, and we maintain a very strict surveillance on all our patients. I have a registry maintained with me, and I keep on calling patients whenever their follow-up is due. At the follow-up, usually after 1 month of thyroxine, this radioactive iodine ablation, we do TSH and regular calcium monitoring so that we can reduce and stop the calcium and carbonate and vitamin D supplements. Also, TSH level should be kept either suppressed or normal as per the age and as per the risk stratification. If it was a low risk CA, then Dr. Amya usually keeps the TSH near normal or just mildly suppressed. If it is a high risk CA, then definitely a higher risk of higher TSH suppression is required. Dr. Amya has come online. Dr. Amya, can you comment please first?
Yes. But the factors, Dr. Amya, you see for the risk of recurrence and then the TSH is the surgical node or the biopsy or the completeness of dissection, all the things which we
Here I would like to comment first that risk of recurrence very much correlates with the completeness of surgery. Here, completeness of surgery is very important because many a times, especially when the surgeons are doing subtotal thyroidectomy, as still is being done in many centers and many places across India, there's a very high risk of recurrence even after ablation. So the option for surgery should be a total thyroidectomy as compared to the subtotal thyroidectomy, that every surgeon should know that abandon the subtotal thyroidectomy, it causes more risk of recurrence and difficult to treat for everyone, either for the nuclear physician as well as the endocrinologist.
Yes, I think I concur with Dr. Ritesh, and I am fortunate to have a good surgeon colleague in Dr. Ritesh, where we usually sort out things very, very meticulously for the patient. And I mean, it's a pain that near total and subtotal are the words that should be actually abandoned, both for Graves' disease as well as for thyroid malignancy. Now, having said that, post a DTC, undergoing through Dr. Gaurav's protocol, Dr. Gaurav sir's protocol, when the patient comes back, obviously, if the patient is young and the tumor is high grade, we'd like to get the TSH suppressed. If not exactly zero, between 0.5 to 0.1 range at least, to avoid toxic process. In an elderly gentleman, you may just relax it to 0.1 to 1 and maintain the TSH on the lower side. Now, obviously, if the person had a positive uptake, that means there is some residue that's left behind, he is due for a scan after 6 months to 1 year based on Dr. Gaurav sir's judgment. And if it has been a very clean job, nothing left behind, then probably what you will be doing is following up the TSH, and even there is enough literature to say that an unstimulated thyroglobulin below 0.2 in such situation is good enough. You don't really need to do a stimulated TG. However, if you get a TG that's more than 1, and if your anti-TG antibodies are negative, then it's a worthwhile exercise getting a stimulated TG or just stopping thyroxine and getting a TG. And it's at times a painful situation where your TGs are elevated and your scans turn out to be negative, and that and your sonography sometimes helps in these situations. Obviously, ultrasound is a part of follow-up every 6 months to 1 year based on what you are seeing in an ultrasound, and then you can take a call on what to do with that particular tennis. It's a case-to-case decision. I have a peculiar question to Dr. Gaurav sir in this situation. I was just going through the recent Williams that, okay, you prefer an iodine scan. Now you have an elevated thyroglobulin. Will you prefer both an iodine and PET scan at that point of time, especially if your prior iodine scan has been clean? And are there any new isotopes in the picture which can be better used to delineate these patients of, I would say, tennis?
This is a very interesting question. See, what happens is one aspect. I'll just tell this in a minute, but about the TSS suppression, I will just share one experience. In last 20 years, I have seen that when I joined RMC 20 years back, every patient of mine post CA thyroid was having 300 microgram of thyroxine. Now all of them are most of the time suppressed on 115, 125 microgram of levothyroxine. So over the period of last 20 years, the dose has substantially reduced to this level, and many of them, and some of them even on 100 remain suppressed. Now coming to your this iodine 131 scan, most commonly encountered problem is iodine scan is negative is because of iodide interference, stable iodine from outside. We have to rule that out in all manner possible, that yes, this is not because of the stable because of any iodide interference. We do not have urinary iodide concentration measurements here in foreign. In abroad, they have urinary iodide, standardized urinary iodide or urinary spot iodine test. So from that they can say that okay, stable iodine is higher. But here we have to ask patient the history, what other medications they are taking, even after discontinuation of amiodarone for months together, still
Yeah.
you can have a substantial iodine within a pool within the body. So that one aspect is there. Second is, if we are TG, when would I measure a TG? I would never measure TG before, and probably you are asking in a follow-up TG, if you are
Yeah,
saying.
follow.
Okay, in follow-up TG, if you are seeing a rising trend in TG, and now people are talking of TG doubling time. So if we are seeing a rising trend in TG, and simultaneously when we have ruled out all iodide interference related things, then obviously with a rising TG, we need to find out with PET scans, FDG PET, which is like a standard of care, to see if we are dealing with some tennis disease. Usually this scenario will not take place so early on in the process. Most of the time, it will be years before these tennis lesions show up. Or if we know about this being an aggressive malignancy. Now, the third thing, whether there are other tests available, people are seeing gallium dotatate, and our group has shown PSMA uptake in these regions. But this is again not a standard of care. We can evaluate these, but when we are talking of day-to-day practice, then if we first of all, I would rely upon sonography in the neck region to see if there is any recurrence itself, and even get an FNA done, or ask my surgeon to even operate upon if there is a positive thing, and then look at the TG, how TG trend plus, which means structurally incomplete disease has to be seen. If structurally, that is through the dynamic risk stratification. All these patients undergo a dynamic risk stratification. Today, they are high risk. Tomorrow, they can become intermediate risk or even low risk. And intermediate risk patient can become high risk in 6 months or 1 year time. Depending on that, we have to proceed. So there are certain investigational modalities which are not standard of care, but yes, FDG PET in case of rising trend, especially in tennis cases, when it is developed, it is important modality.
Thank you, sir. Thank you so much. So there's not much time left. So we have 2 or 3 questions coming from the audience. So I'll just quickly take 2 or 3 minutes more. So one is important one is stage 3 and stage 4 Bethesda atypia or follicular neoplasm. Would you go for total thyroidectomy or lobectomy? So how do we deal? We don't have molecular diagnostic test available with us. There is a patient who has got nodule. We did the FNA and it was found to have atypia of undetermined significance. So Bethesda 3, Dr. Hitesh, Dr. Amya, please. Whether lobectomy or total thyroidectomy.
In such scenario, we discuss every time with the patient, and we see whether the patient is having solitary nodule or a multinodular goiter. If multinodular goiter, we request the patient to go for a total thyroidectomy. If solitary nodule and patient is opting for hemithyroidectomy, most important is frozen section biopsy during surgery. Without frozen section biopsy, a hemithyroidectomy should not be done, especially in the Bethesda 3 and Bethesda 4, because it changes the decision during surgery. If it turns out to be malignant on frozen section biopsy, we can do the completion thyroidectomy then and there only, and avoiding the second surgery and avoiding the risk of any future recurrent laryngeal nerve injury and hypoparathyroidism.
Yeah, the risk of malignancy in, I think, Bethesda 3 is around 20 to 30% and close to 40% in Bethesda 4. Right, sir, right. And there's one more question. Graves' disease patient with severe ophthalmopathy underwent total thyroidectomy. Histopath showed micropapillary CA. Should we go ahead with ablation? The risk versus thyroid associated orbitopathy exacerbation, or whether we should watch and treat, we should basically follow up with the thyroglobulin levels. It's an interesting question, actually. So probably it would depend on the extent of surgery and other risk factors. If it's a micro papillary CA and no other risk factor, please comment on the panel. Patient has got active thyroid disease and or the severe Graves' orbitopathy, Graves' disease, and then papillary CA was detected on after completion, means after removal of the. Though these patients rarely undergo total thyroid.
Yeah, let us take it on merit. And I think if there is no harm in getting a diagnostic scan and a TG level in such a patient, and if you find that there is a residual disease on a scan and the TG level is high, so it's worthwhile putting the patient through an ablative therapy, and then it can always be done under a steroid cover.
Steroid cover, yeah. And even after thyroidectomy, the antibody level will also go down. Probably the risk
Yes,
of
so
neuropathy will
it's,
go down.
yeah, I mean, that's what, and I mean, on that previous question of an indeterminate thyroid nodule, I'll always say that your Bethesda is indeterminate, but you have other pointers. In a male of 50 years with a 5 centimeter nodule, which is Bethesda 3, I don't think there is anything to decide. He is the candidate preferably for hemi with frozen, or if you find it really bad on sonography, I think you have to take a holistic decision considering all factors in mind. At the 80 years, I think you can just leave it and maybe, and that's where role of molecular markers is. But I must tell you that Afirma in Mumbai costs anything like 1.75 lakhs. I mean,
And again, then probably it won't help after it. It
Yeah.
will not help actually. And the cost of recombinant TSH is one other question. It's probably 90,000 for one shot, I think, sir. Close to 1 lakh for 0.9 nanogram, I think.
0.9 milligram
Milligram, yeah.
dose per dose, and it is quite costly. And about that Graves' disease thing, Graves with differentiated thyroid cancer is an aggressive thing. On what we observe on radioiodine scan is that the uptake will be phenomenally high. Normally, when our surgeons at Tata, when Dr. Ritesh is sending patients, we always get an uptake of 1 to 5%. I don't, after seeing an uptake, I know who is the surgeon who might have operated. Is it a high volume surgeon? So for there, or is someone else? Moment I see the uptake in the picture, I know बाहर से आया है, अच्छा नहीं डॉक्टर रितेश ने भेजा है, तो वो मालूम चल जाएगा immediately. Now the thing is, this Graves scenario, once there is have Graves along with DTC, even with the best of operation, because fundamentally the residual tissue itself has got a very high biological activity, gives more uptake, relatively more uptake, 10 or even more percent. So you shouldn't be worried on that front that completion surgery nahi hua hoga. That's not the scenario. And plus, Graves with DTC is aggressive, so it has to be treated that way.
Ma'am, can we take 1 or 2 questions more? Or?
Yeah, there are some questions. Yes, go ahead, please, Rajat.
Yeah, thank you, ma'am. So there's one question is the presence of Graves' disease can lead to overdiagnosis of papillary CA in FNA due to Graves induced histological changes per se. So any comments? We don't have pathology.
What I understand is that they wanted to know whether Graves can lead to an overdiagnosis, and that was a criticism that was often thrown on what I would say typically European endocrinologists who used to do an FNAC themselves in every thyroid that they got. I would tell you one simple thing, that if you get the classical nuclear grooved appearance,
only
I think it has to be, you can't ignore that. And time and again, I mean, if you have a nodule that is well defined in a Graves and it's yielding you something on histopathology, I think by clinical judgment, these things can be sorted on case-to-case basis. There can always be ambiguities, and there can always be a second day when you see that particular patient after say 6 weeks or 3 months. But I mean, yeah, that's
nuclear grooving suggests papillary CA.
Yeah. So if you see some classical findings, I think you have to give it. So as you correctly said, Dr. Rajat, it's not that the Bethesda is the end that you see. We all read in between the lines and sometimes even reclassify things on our own.
Okay. So one another question is how to prepare patient for radioiodine scan post total thyroidectomy, both by recombinant TSH and Linorma. Dr. Gaurav, please, if you can say.
As I told, for recombinant TSH, the main thing is iodide interference. One should be, suppose if pre-operatively most of these patients do undergo contrast enhanced CT, and so we have to wait for 3 weeks anyhow, and that is also the time for kind of healing that to take place. Now, in this duration, if patient has not been put on has been put on levothyroxine and is not hypothyroid, then one can go for recombinant TSH. And after recombinant TSH injection of 0.9 milligram on 2 different days, TSH level can be measured, and simultaneously we can administer radioiodine and do the scan. Or else, normally 3 weeks down the line, most of these patients achieve a TSH of more than 30. Many achieve even at 2 weeks, we have seen. which is again a different practice point. Over the last 2-3 decades, the thyroid size has reduced, the general population because of iodization program. So for thyroid hormone withdrawal, again, we have to ensure all the iodide interference related thing on iodine, low iodine food, and then we give 1 millicurie of radioiodine and do scan on the whole body scan on next day and see. Is there any specific thing I am missing? Please.
No, sir. I think we do radio scan with 131 or 123, sir. 131 only.
No, iodine 131. Iodine 123 is not available with
Not
us.
available.
But if it is available, we would always prefer giving iodine 123 because it will not cause what is known as phenomenon of stunning. Iodine 131, we have seen the only institution in the country which now we even don't do that is was RMC, our institution, where we used to do 100 microcurie I-131 uptake. That never caused stunning, but I have seen stunning even with 1 millicurie scans. So phenomenon of stunning is when we are given radioiodine in the diagnostic scan, we see the uptake, but if we have not treated, if there is a gap between the diagnostic scan and the treatment scan, then we do not see anything in the post-therapy scan. This is especially more with the diagnostic dose like 5 millicurie or 10 millicurie. Sometimes some institutions will give 3 to 5 millicurie dose. The stunning will be more. So with iodine 123, you would never find stunning. Plus in iodine 131, you have to do scans at 24, 48 hours. When you have given a dose of say 3 to 5 millicurie for gut clearance, you have to do scans at a later time at 24, 48 hours. On the other hand, with iodine 123 on the same day after 6 or 8 hours, you get the similar kind of information. So, but iodine 123 is right now not available in our.
Dr. Tesh wanted to add something.
Yeah, because we are towards the completion of the session, so I would like to comment just 2 things. With so many years of practice and thousands of thyroid operated by me, there is a referral bias towards me always as a specialist surgeon, but the rate of malignancy in my own data has been near in thyroid cancer, in thyroid nodules which I have operated is nearly 40%. 40% is a huge number of malignancies in all the thyroid operated by me, and this cannot be neglected by others. That no, benign nodules will not have malignancy on sonography features or FNA. So please be very, very cautious whenever you are dealing with thyroid nodules. And second thing, differentiated thyroid cancer treatment management is always a team approach. I am very lucky since the beginning of my practice that the captain of the ship, Dr. Amay Joshi, the endocrinologist, is always there to help me. And nuclear guy, Dr. Gaurav Malhotra, he has taken care of so many patients of my thyroid cancer. And we always discuss each other in every difficult patient how to go ahead. So that is why the patients get the best management. And remember, the best management of the patient is their right. We should opt always for the best and nothing but the best.
Right. Amay, you want to add something? The final comments.
Sir, I add some questions on chat box. Which are the live questions.
I'm afraid we cannot continue because we have the quiz and then we have the talk. So those questions can be addressed later.
Right. So there are a lot of questions.
I'm sorry for interrupting, but.
Yeah, ma'am. Thank you. So we can close our panel discussion here, ma'am. Yes.
Thank you.
Thank you. Thank you.
Thank you for having us.
Thank you.
Thank you, panelists and moderator Dr. Rajat Gupta, sir, for a very captivating discussion. So before we go ahead with the quiz, I request Dr. Arun Menon, sir, to present a few slides regarding the ITSCON. So over to Dr. Arun Menon, sir.
Thank you, Ganvi. Good evening, everyone. I take this opportunity to welcome you all to the Indian Thyroid Society National Conference, ITSCon 2023 in Kochi. This will be on May 27th and 28th at Le Meridian, Cochin. So we have got an exciting array of talks and programs. Our international panel includes Professor Susan Mandel, whom many of you might know fairly well. There is Dr. Kim, who is the current IOTA president, Dr. Raza, and Dr. Dimutu. So I think it's going to be an exciting international panel. I would also like to highlight a few aspects of our meeting. Can you go to the next slide? Yes. I would like to highlight that we have got the abstract submissions still open. We have extended the deadline to, we have already had quite a few abstracts coming in. We've extended the date to 31st of March. So please send in your abstracts. So that is number one. Number two is we have got an exciting, again, next slide, please. We have got, maybe the next slide. Yes, we have got an exciting quiz competition, which I'm sure will be, there's a young and exciting team who is doing this. So I'm sure this will be a success and a hit. And we also have a pre-conference workshop, which will be on thyroid ultrasound. This will be again led by Professor Susan Mandel, along with Dr. Krishna Sheshadri and Pramila are all part of it. So this is going to be the program. The scientific program will be out in the next week or two. Please go to our website and please look through. And if you're interested, please register. Thank you.
Thank you, sir. So I now request Gatnati sir to introduce Dr. Srinath, our quiz master for today's session.
Yes. Now coming to the very interesting part of the session today, the quiz which we'll be having, it will be conducted by a young and dynamic endocrinologist, Dr. Shetty. Dr. Shetty, he is Assistant Professor of Department of Endocrinology at Kasturba Medical College, Bangalore. He's done his DM from CMC Vellore. His various awards and achievements: second place in Capicon quiz. He was a TISA Quiz Journal 2011 winner, and he's member of various societies like ESI, Karnataka Endocrine Society, Bangalore Endocrine and Diabetes Society, and the ITSCON. Over to you, Dr. Srinath Shetty.
So before we start, we will just display the quiz questions.
Yeah.
Sorry,
Srinath,
the quiz participation rules. So again, to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. The first two, there'll be dummy questions followed by the actual quiz. The quiz master will display the case or the description by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All the 10 questions will be available when the poll is launched, and the answer for all the questions will be submitted at the end of 10 minutes. To read the case or description, you can use the polls option using the X button, and again use the polls option to answer the respective question. So I think the dummy questions were already displayed prior. So because we are running short of time, I request Dr. Srinath Shetty sir to display the slide.
Thank you for the kind introduction, Dr. Vikrant. Thank you, Ganvi. So I'll directly go to this quiz. So I hope the slides are visible. Dr. Ganvi has already told the rules. We have 1 minute for each question. There are 10 questions. And the decision of the quiz master is final. So the first question.
I'm sorry, it's not 60 seconds.
Huh.
Which is barely 10 seconds per.
Yeah, 10 seconds per question.
60 is very long, I'm sorry.
Fine. Okay, 10 seconds per question. So which drug used in critical care illness can generate free fatty acid and cause pseudo increase in free T4 level? The options are A, terlipressin, fentanyl, dopamine, and heparin. So the poll is there.
Yes, sir.
So I'll go to the next one. Technical team, I can go to the next slide, right? Next question.
Yes, sir. Yes, sir.
Yes, thank you. So the next question, 20-year-old gentleman who has come with difficulty in getting up from chair from the past 3 months, from past 1 month, and he has history of thyroid surgery done 3 years back, and which the details are not available. He has lesions in the tongue, skin hyperpigmentation, proximal myopathy. On biochemical evaluation, potassium was 2.8, bicarb was 32, serum cortisol baseline was 19.4, ACTH of 316 picogram per ml, what's the likely diagnosis? Option A, thyrotoxicosis with hypokalemic periodic paralysis, medullary carcinoma thyroid with ectopic Cushing's, Littleman syndrome. Last option, Cushing's disease. So I'll move on to the next one. Question 3. 58-year-old gentleman who is come with history of total thyroidectomy. He has history of papillary carcinoma thyroid, 2.5 centimeter, with extensive extrathyroidal extension and vascular invasion. 7 out of 8 lymph nodes were positive for metastasis, and he received radioactive iodine 150 millicurie, followed by levothyroxine of 150 microgram. So now during follow-up, his TSH was 1, thyroglobulin was 3 nanogram per ml with no anti-TG antibodies. His levothyroxine dose was subsequently increased to 175, and recombinant TSH radioactive iodine scan was done, which was negative. However, his stimulated thyroglobulin concentration during follow-up was 10 nanogram per ml. Neck ultrasound was unremarkable. CT scan showed a right lung nodule, and 2 years after the surgery, his TSH is low, that is 0.08 milli international units, and thyroglobulin has gone up further to 12. So what is the next best step? Option A, administer radioactive iodine therapy with 150 millicurie, perform FDG PET, initiate tyrosine kinase inhibitor therapy. Option D, increase levothyroxine dose to suppress the TSH further to 0.01 milli international units per liter. I'll move on to the next question. Question 4. Thyroxine was synthesized by Charles Harrington, Charles Herbert Best, Rosalind Sussman Yalow, Thomas Killick. Moving on to the next question. What is the scoring system used to predict the recurrence of hyperthyroidism after antithyroid therapy in Graves' disease? Option A, CA score. Option B, TIA score. Option C, grade score. Option D, Predigo score. Moving on to the next question. Which of the drugs inhibit conversion of T4 to T3 except glucocorticoid? Option A, option B, phenytoin, option C, PTU, option D, amiodarone. Moving on to the next question 7. A 19-year-old girl comes to OPD with skin hyperpigmentation and elevated TSH, suggestive of a primary hypothyroidism. She is diagnosed to have diabetes at the age of 6 years and is on insulin since then. She also has other problems like short stature, primary amenorrhea, poor secondary sexual characters, hearing impairment, and hypertrichosis involving the lower limbs. What is the most likely diagnosis? Option A, mitochondrial diabetes. Option B, drug-induced hypertrichosis. Option C, H syndrome. Option D, Cushing's disease. Moving on to the 8th question. Which enzyme present in raw bok choy, that is white Chinese cabbage, is responsible for precipitating myxedema crisis? Is it myrosinase, tyrosinase, avidin, or pepin? Question 9. Which level of serum T4 is associated with close to 80% probability of death in patients who are critically ill? Is it below 4 microgram per deciliter, below 3 microgram per deciliter, below 2 microgram per deciliter, which is option C, and below 1 microgram per deciliter, which is option D? Moving on to the last 10th question. Which of the following reasons, sorry for the mistake, explains the elevated TSH in patients with primary adrenal insufficiency except? Is it decreased sensitivity of thyroid gland to TSH, impaired metabolic activity of thyroid hormones and the action at its receptor, Schmidt syndrome, or anti-TPO, option D, anti-TPO body antibody levels are always negative? Last 5 seconds. Yes, that comes to the end of the quiz.
Thank you, sir, for a very interesting quiz. So I now request Gatnati sir to introduce our esteemed speaker for the monologue, Dr. M.J. Paul sir. So the answers for the quiz will be discussed at the end, followed by the announcement of the quiz winners.
Yeah. Good evening, everyone. Again, it's a pleasure to introduce Dr. It's a pleasure to introduce Dr. Paul sir. He is a professor and head Department of Endocrine Surgery at CMC Vellore. He has been the former president of Indian Association of Endocrine Surgeons, and sir has done his MS in general surgery, and then he's done specialization in endocrine surgery across Germany and United States. His area of interest include the endocrine tumors, thyroid, and the breast diseases. His area of interest is minimal invasive surgery of the adrenal, the parathyroid, thyroid, as well as the pancreas. He is also interested in surgery of advanced endocrine and breast tumors. His out of topic interests include bioethics and also medical legal issues. He's got a number of more than 100 plus publications, and he's been an author in more than 6 books. He's achieved various awards. He's been awarded with Linnaeus Prom Visiting Teacher Award at Sweden. He's been a part of the Obama Singh team of grant of bioethics at Boston, USA. He's given Jai Shekar oration at ASI Nagarcoil. He's given the TC Goel guest lecture at KGMC Lucknow. He's given the Krishnamurti oration at ASI Mysore in 2016, and he's given the KD Verma oration at Tirupati. And he's been a guest speaker at the Indo-UK Breast Forum in 2021. Really, we have a very distinguished speaker amongst us all, and sir will be talking about the medullary thyroid carcinoma, and he'll be enlightening us regarding this. Over to you, MJ Paul, sir.
Thank you so much. Hope you can hear me.
Yes, sir, you're audible.
Okay.
Please go ahead, sir.
Thank you, Dr. Vikant, and especially to the whole ITS team and Ritesh for this invitation. Late night, but a good time to think about topics. So after a long OPD, I am sharing with you my experience in medullary cancer thyroid. Let's see if this, my screen has come on.
Yes, sir.
Just put it into full mode. Now it's okay.
Yeah.
Okay, so the topic is medullary cancer. So the outline is that I'll take you through some of the genetic aspects, the guidelines with reference to management, case discussions, and our experience at Vellore. So it will be a mix of this. Initially, we need to look at the demographics, and medullary cancer thyroid is a tumor of the C cells, as we know. And the recent literature says that the percentage of all thyroid malignancies varies from 1 to 4%. And the percentage of deaths but is much higher at 15%. So we can see that it's more aggressive than its well-differentiated follicular cell counterparts. While 75% are sporadic, 25% or 1/4 of tumors are hereditary and can be proven through genetic analysis. So the germline activating point mutations in the rearrange during transfection, which is called the RET gene mutation, they are associated with the hereditary MTC. These mutations are inherited in autosomal dominant manner. Therefore, offspring have a 50% chance of the mutation. If we look at the historical developments, the first mention of this kind of tumor is actually way back in 1906, before a definitive histological description only came in 1959. The MEN2 was first described by Sippel, 2B by Steiner, familial medullary thyroid cancer in 86 by Founder. It was 1985 that the RET gene was first identified, and that set the stage for a much greater understanding. The location on chromosome 10 in 87, soon after. And then by then, 1993, all the mutations of the MTC syndromes had been identified. Currently, there are more than 100 mutations described in the RET protein structure. So this is a picture of the protein structure on the left. And to the right, as we know, when it's activated, it dimerizes and has 3 tyrosine points of combination. And this is what creates the stimulation of the intracellular pathways for cell division. So here's a sort of picture of the RET protein structure. You can see there's an extracellular component, which is across the cellular membrane, and an intracellular domain. And the codons align from 609 outside right down to 918. And interestingly, it seems that the lower, more intracellular the domain mutation, the more aggressive the disease. We know that 918 is probably the most aggressive. This is the current classification as of 2015. We have MEN2A and 2B syndromes. And what is important for students and others to realize is that 2A is by far the most common, much more common than the 2B syndromes, 95% versus 5%. This is rare to see the MEN2B. Many of us would have seen probably 1 or 2 cases in our whole career, and many surgeons, even thyroid surgeons, may not even have seen this. It's so rare, and it's also very lethal. So not many actually survive to create offspring. The MEN2A was further subclassified into 4 different types. The classical 2A, which is MTC, medullary thyroid cancer, FEO with primary hyperparathyroidism. MEN2A with cutaneous lichenoid amyloidosis, it's called 2A with CLA. Then there's 2A with Hirschsprung's disease. And lastly, familial medullary thyroid cancer, where the only presentation is medullary thyroid without either FEO or PHPT. So these are all variants of the 2A syndrome. This is an example of the MEN2A cutaneous lichenoid amyloidosis, and there's a dark patch which almost looks like a fungal infection in a way. It can be pruritic as well. The most common location is the upper back around the scapular region, but it can be lower as well. It's not to be separately treated, but it's important to realize that this can actually precede the development of NTC. Therefore, in children or young adults, it can be, if an astute clinician picks this up, it can be actually the first identifier that this person has the disease and lead us to check for MEN2A. MEN2A with the Hirschsprung's disease phenotype. This is an example of a case we had to do the laparotomy many years ago, a 55-year-old woman for the pheochromocytoma. And there was a megacolon which had been picked up on the CT. So you can see this is what the Hirschsprung's colon looks like in an adult with the MEN2A HD phenotype. This is the MEN2B phenotype. which is very classic in terms of the marfanoid habitus. What is less commonly noticed, as in this individual, you can see is the neuromas that can be along the eyelids as well as the tongue and lips. This is a very full-blown classic case, high arched palate and the marfanoid habitus. Unfortunately, this is very severe and so presents early and can be aggressive. In fact, this particular patient even had malignant MTC, which had metastasized by that time he had presented, and had even produced a paraneoplastic ACTH production, causing a Cushing's in addition to the MTC, a very severe disease, and he unfortunately did not survive this. This is current guidelines which are all available. The ATA last one revised in 2015. There's the National Comprehensive Cancer Network, NCCN 2012, European Society, British Thyroid Association, Brazilian and North American Network. All these societies have put out guidelines. The most comprehensive one, of course, is the revised American Thyroid Association guidelines. And this is a large document brought forth by a multidisciplinary task force, 67 recommendations in a 44-page article. So some of the guidelines can be classified as to what is the risk level of these mutations and the aggressiveness, and therefore what should be the timing of prophylactic surgery. You can see that it's now been classified into moderate, high, and highest risk, which is a change from the earlier. And the highest risk has only the 918, or the lowest codon mutation, intracellular, that can present the first year of life. So this is usually very aggressive again and very rarely picked up. We haven't been involved in such a situation. The high risk ones, the commonest, which is 634 and the 883, and this can present even as early as less than 5 years. So at 5 years, you have to consider whether to go in for prophylactic surgery based on the serum calcitonin levels. All the others fall under the moderate risk category and usually present in adulthood. So when serum calcitonin is elevated, you can go in, or earlier before elevation as a prophylactic option if the family so chooses. So it's this one, you don't have to go for prophylactic. You can offer the option of calcitonin screening on an annual basis. So patients with presumed sporadic MTC can be an indication for red testing, and that's say somebody comes with only the MTC, or thyroid nodule with lymph nodes, FNA says it looks like MTC and the calcitonin is elevated, but there's no other feature of pheochromocytoma or primary hyperparathyroidism, then still all these have to be checked, because MTC is the first presentation and therefore can still represent a hereditary index case. Then there's of course members of known MTC kindreds. So if you have an MTC patient and their siblings, interestingly, we've had situations where, you know, the child, I mean, a young adult comes in with MTC, and then we check the father. 2 patients who had like that, and found that he's actually sitting in MTC unrecognized. And we know that there's a phenomenon what we call anticipation, where the next generation disease of inheritance presents earlier because they've acquired more aggressive mutations in the same gene. So we even have families where you have grandparent at 70 was discovered, the parent around 50, and then the child around 30, 35. So that is something we have to be aware of, and we always advise screening next generation 1 or 2 decades earlier must be done than the parental presentation. All patients with pheochromocytoma must be evaluated for red as well. So all MTCs and all POs now get the test. Pheochromocytoma, of course, has different mutations, but one of them is the red mutation. Then we have patients rarely who present only with this cutaneous lichenoid amyloidosis, and as I said, it may be the first presentation. Therefore, they may not have the MTC yet, so they should be screened as well for it, and Hirschsprung's disease as well. So now it's interesting. What about testing calcitonin on thyroid nodules, should we be doing it as a basic evaluation? It's a point of debate. It's recommended by the European Thyroid Association, but not recommended by the American Thyroid Association. So obviously, usual practice is somewhere in between when you have two extremes. So a pragmatic approach would be, if it's not clearly benign on FNA or not clearly malignant like PTC, and it's an indeterminate atypical nodule, then to add to your diagnostic module, you might add calcitonin as an additional marker. We don't practice routine, only selective. One of the clinical points we've noticed is that thyroid nodules or the lymph nodes, if it presents with lymph node metastasis, tend to be a little tender. Still not clear in literature, but we found that in several patients. So if you do have a nodule or a node that feels tender, then that's a wake-up call that it could be medullary, and we would do a calcitonin. Of course, aggressive nodal spread is another indicator that it could be medullary. So those are the situations where we would use calcitonin as a diagnostic tool. Now, we must be aware that there are false elevations in ectopic neuroendocrine tumor secretions, in PPI usage, antacids, pregnancy, and hypothyroidism can all elevate the calcitonin slightly. CEA is the other marker which we use in known cases, but it's not been shown to be useful in the diagnostic setting. But it's very useful when there is advanced disease in follow-up and you want to assess the metastatic load. It is more sort of consistent with the metastatic load than the calcitonin as well. Now, other diagnostic tests which can be done, interestingly, people have actually used the FNA aspirate washout. So where you do an FNA, you push the needle content into a solution and send it for checking the calcitonin level, just like we do the blood sample. And that was actually found to be even more sensitive than the FNA cytology for diagnosing nodal mets and for the thyroid nodule in some studies as well. So that's something that can be considered. We even use it for thyroglobulin in well-differentiated follicular tumors, but it's being described for medullary as well. Now, there are certain immunohistochemical markers that are under evaluation, not routine tests, like thyroid transcription factor, TTF, PAX8, and calcitonin gene-related peptide. These are under evaluation. Now, miRNA is the other microRNA, can be used both in diagnosis and prognostication. So here we use a liquid biopsy, and that is a blood sample where the genetic content is assessed for circulating microRNA and cell-free DNA. So the microRNA is used in post-transcription control of gene expression, as we know that's a role, and it can predict red mutated tumors if you have upregulation in the mRNAs which are listed there, or down regulation of the mRNAs that are listed. You can also do a differential pair analysis where you use different mRNAs to check both upregulation and downregulation. The combination gives a selective assay. And there's even 375 and 183 mRNA that can predict mortality and lymph node mets. These are all recent data that have come out and things that we need to consider if we are in this area. What about nuclear medicine scans? There's been development here as well, apart from ultrasound, CT, and MRI, which is cross-sectional imaging. We can use specific scans. What's commonly used is the DOPA PET and is in the recommendations of the ATA. I'm sorry, the ESMO, but not in the ATA. Whereas the newer scans, which is gallium-68 rotate PET, is what we use at Velo, very sensitive, and seems to be now the imaging of choice. Ones that are now newly developed is the variant of gallium 68 rota MGS5 PET scan still under evaluation, and the IMP 288 gallium scan again also recent entry. So I think most centers in India do have a gallium rota date, so that is something we use for diagnosis, both in the primary setting for extent as well, especially in the follow-up metastatic setting. The primary treatment for medullary cancer would be total thyroidectomy with prophylactic bilateral central node dissection, meaning both paratracheal compartments for more than 1 centimeter tumor, therapeutic IPSI or bilateral neck dissection. That means we have identified clinically or radiologically or intraoperatively significant nodes and therefore become therapeutic. So we consider ipsilateral prophylactic dissection for gross disease in the central neck. So if you see paratracheal lymph nodes, then it makes sense to go into the lateral compartment. So I'll try to go one step ahead because we know that medullary cancer lymphatic spread is more aggressive than well-differentiated papillary cancers. We consider external beam radiation if there's gross residual disease. We use replacement thyroxine and not suppressive doses to keep the TSH in the normal range. And after initial thyroid surgery, ultrasound is used for residual neck disease. Calcitonin and CA are the markers for follow-up. Now, if there is primary hypoparathyroidism associated, for a single adenoma we excise it, for multiglandular we leave the equivalent of 1 gland. Cryopreservation was thought of earlier. We've never been in it, and recent data suggests that it may not be that effective. So I'm not aware of any centers in India that are doing cryopreservation or have used it in a therapeutic. Now the post-operative management requires 2 to 3 months. We check calcitonin and CA. Now, interestingly, calcitonin is supposed to have variants that may take time to come down in the blood level. Therefore, immediate checking is not recommended. To get the true value, you need to wait for 3 to 4 weeks after surgery, and that is in most recommendations. So if a calcitonin is more than 150 picograms, that would indicate there may be metastatic disease, and we need to do cross-sectional imaging or specialized nuclear scan like gallium rotate. Calcitonin doubling time has been used. So if it doubles in less than a year, it suggests more aggressive disease, and additional imaging should be done in such a situation. Now, calcitonin can also be used to direct the necessity for nodal dissection, especially for adding on lateral. So if the calcitonin is less than 20, then it's unlikely there is nodal involvement when you're in a setting of prophylaxis typically. In patients with ultrasound showing no nodes, then ipsilateral central and lateral dissection should be considered if the calcitonin is more than the range of 20 to 40. In ultrasound positive lateral neck, contralateral dissection should be considered if more than 200. That means we've got a right-sided nodule and right-sided nodes, which have significant nodes, and even associated calcium over 200, and better even go on the opposite side and take out contralateral lateral neck. This is called calcitonin-directed node dissection. Persistent or recurrent disease, if it's leukoregional, then as far as possible, we resect and add external beam radiation. If it's unresectable, then the TKI vandetanib can also be used. Symptomatic mets, palliative resection, ablation, RFA chemoembolization, these are all ablative methods that can be used apart from radiation and TKI. If it's asymptomatic, it's best to observe and follow up and see the development, the doubling time, the structural increase on imaging. resect it if it's possible, or use ablative or TKI. A disseminated symptomatic disease, then it's better to get on to a clinical trial. We can use targeted external beam radiation, newer TKIs like selpercatinib, dacarbazine, which a trial is going on at the moment. I listed it here. Best supportive care if all else fails. Now, locally advanced disease such as this sometimes requires sternotomy for resecting the advanced lymph nodes that can be right down the whole mediastinum, and a multidisciplinary team should be used to make these decisions. Now, some data from our own center, although the literature suggests 1 to 4% is the range in large series or databases. In our center, we found it was as high as 5% of the cancers that we were seeing, probably related to referral bias because of the endocrinology and endocrine surgery team that is available. So this is the data we have on the mode of presentation. We analyzed 76 cases, and we found in 55 sporadic cases as well as 21 hereditary cases, the most common presentation was goiter plus lymph nodes. So nodule thyroid enlargement or nodule presenting with lymphadenopathy is the most common presentation. In the hereditary group, of course, it could be pheochromocytoma or screen detected. The others may be just a solitary nodule or dominant nodule or multinodular goiter, can be presenting with recurrent lymph nodes after primary surgery done some time back. The red data that we have on 90 patients, we did the test in 71, so about 80% were screened for RET. 25 were positive for RET mutation, which is a rate of 35%. And all of them in this database were MEN2A syndrome. So here you can see the type of RET mutations is 634 is by far the most common, 12, 8048, 790 codon mutation in 3, and 618 mutation in 2. The presentation of the RET mutated ones, you can see, was most common goiter plus lymph node in 66%. Just an example, a family story where the mother presented with pendulary carcinoma thyroid, underwent surgery, then had a liver metastasis, and that was resected as well, and then had lung metastasis, was managed with TKI as well as ablation using lutetium directed ablation, but finally succumbed to the disease. Whereas the daughter, who was detected by screen detection in teenage as a 634 mutation, underwent prophylactic thyroidectomy at 13 and found micro MTC, but not spread to the lymph nodes. And at 18, when she just joined college, screen detection was detected to have pheochromocytomas, underwent bilateral adrenalectomy, and is doing well now, 15 years from the prophylactic neck surgery detection. So we can see, because of the generational difference, the availability of screen detection, we can alter the profile of the clinical profile of the disease. Another example of an 804 mutation where the mother presented actually with a thyroid nodule which is invading a trachea, extremely rare case where medullary cancer went intratracheal. It's the only case that we have. Underwent, in fact, a tracheal resection with a neck dissection and external beam radiation, and has been under control for more than 10 years now. And her sons, both of whom were tested and found to have 804 mutations as well. But as we said, this 804 comes under the moderate risk category, does not require prophylactic, and be given an option surgery. They were given the option and they opted to be on annual screening. They've been on annual screening for 10 years and so far no evidence of disease. So this is the sort of clinical pattern that we see, and each case managed according to codon mutation makes it more targeted and better for the individual. So with that, I want to thank my own team, the multidisciplinary conferences we have, and my colleagues in the department. Thank you very much for listening.
Thank you, sir, for the very excellent talk. So moving on, I request Dr. Srinath sir to present his slides and discuss the answers for the quiz questions, followed by announcement of the quiz winners.
Yeah, sure. Thank you. Let me just share the screen. Okay. So the answer keys. The first question was on critical illness. Which drug increases the free fatty acids and leads to pseudo increase in free T4 levels? The answer is heparin. Basically, heparin, when we use it, increases the free fatty acid, and this free fatty acid displaces free thyroxine from the bounded protein, and that is why you get a falsely elevated free T4. The other options, that is terlipressin and fentanyl, has nothing to do with thyroid hormone levels. Dopamine can act centrally and reduce the TSH production. Coming to question 2. Question 2 was a lengthy question. It was based on a case which we saw when I was in CMC Vellore. It's a 28-year-old gentleman who has history of a thyroid surgery, details of which were not available. But the classical finding here was of the neuromas that is there in the tongue. So neuromas in the tongue and lips are very classical of meant to be syndrome. So this patient had meant to be syndrome. And if you look at the examination and biochemical evaluation, there was hypokalemia along with alkalosis and elevated, though baseline, we don't have the rest, overnight DEXA and other things, but you know that the cortisol levels are high along with high ACTH levels. And that is the reason why this patient has hypokalemic weakness. And the reason why this patient has elevated ACTH in this picture is an ectopic Cushing, so which is documented in literature, a source of ectopic ACTH. The other options can cause hypokalemia and alkalosis, but not the answer here. Question 3, this was discussed today. 58-year-old gentleman who had thyroidectomy and during follow-up noted to have serially elevated rising thyroglobulin levels, but not picked up on imaging or iodine scans and what we call tennis syndrome. So how do you go forward? So going forward, the answer is to do a FDG PET CT. This would pick up the lesions. As in the panel discussion, they also spoke about Dotanoc and other scans, which can also be used to pick up these lesions. Question 4 was who discovered thyroxine? It was discovered by Charles Harrington, and the other options, Charles Herbert Best was known for discovering insulin. Rosalind Sussman Yalow was the one who found out radio immunoassay, and Thomas Killip came up with the classification for heart failure. So coming to the question 5, which of the scoring system helps in predicting recurrence of hyperthyroidism in patients with grave disease? The answer is GREAT score. The other scores that were mentioned, CAS's clinical activity score used to look at the activity of thyroid eye disease. TIA score is basically to look at the predictions of hypothyroidism or hyperthyroidism in a patient who comes to the clinic. Predigo score is basically to look at the again for thyroid eye disease. Here it was basically to look at whether the patient is going to have a progression of the thyroid eye disease or not. Coming to question 6, what are the drugs which inhibit T4 to T3 conversion except? So the answer is phenytoin, amiodarone, PTU, and glucocorticoids. All of them reduce T4 to T3 conversion. Question 7, again is a case, a 19-year-old lady coming with skin hyperpigmentation, elevated TSH. Other things that were to be noted was primary amenorrhea, that is hypogonadism, hearing impairment, and hypertrichosis. So this is more of a spotter. This was an H syndrome, which is similar to mitochondrial diseases. So they present with these, so 5H, that is hypogonadism, hypertrichosis, hearing impairment, and hypothyroidism. So the other diseases can cause hyperpigmentation, but if you look at mitochondrial diabetes, it is similar picture, but you can't explain hypertrichosis. Cushing's disease, you'll see hyperpigmentation. Again, hypertrichosis is difficult to explain. Question 8. Which enzyme is present in raw bok choy, that is Chinese white cabbage, which can precipitate myxedema crisis? The answer is myrosinase. So myrosinase is nothing but thiocyanate, which inhibits iodine absorption by the thyroid. So these are basically substances that are produced in cruciferous vegetables to protect them from herbivores. So they cause a pungent smell with which the herbivores won't feel like eating them. So unfortunately, they also reduce the iodination. Tyrosinase is enzyme used in melanin synthesis. Evidin binds to biotin, can cause biotin deficiency. Papain is basically a digestive enzyme seen in fruits, also has healing properties. So the level of T4 that is associated with 80% mortality in critically ill patients. So here we are discussing about sick thyroid syndrome. So any level below 2 microgram per deciliter is a indicator of very severe sick patient and sick thyroid syndrome. Last question, which of the following reasons explain elevated TSH in primary adrenal insufficiency? So this was picked up from our journal. So basically, there's a case report in 2021 where the subject had elevated TSH and low cortisol. And once the glucocorticoids were replaced, the TSH improved on its own. So the patient did not require thyroxine supplement. So there are various hypotheses that were suggested. One is the decreased sensitivity of thyroid gland to TSH, hence the high TSH. The other thing is at the hormonal level, at the cellular level, the thyroid hormones T4 and T3, they action their slight insulin resistance. So that's why the TSH goes up. Then you can have Smith syndrome, which is autoimmune adrenal insufficiency and hypothyroidism, which can present together, which can be there in some cases. And since most of the reasons where you see both together are autoimmune, anti-TPO antibodies are usually positive. Only some of them it is negative. So with that, that's the answer key. Can we have the winners, please, technical team? So the quiz winners for today's session are Dr. Bharti in first place, Dr. Raghavi in the second place, and Dr. Saurabh Sagar in the third place. Congratulations, all of you. Over to Gani.
We request all quiz winners to please put their email IDs in the chat box, please.
To receive the certificates, right, Asmita?
Yes, ma'am.
Yes, ma'am.
Thank you, sir, for a very interesting discussion and regarding the quiz. So now we will display a few slides regarding the ITSCOR, the tech team. Yeah. So the ITSCON will be held in Kochi between May 27 to May 28 and May 28. So the delegates, the PG students, and the accompanying persons can register at that website, that is www.itsconconference.in. So there are both international and national faculty. There are various symposia available. Also, there's a pre-conference workshop on ultrasound of the thyroid. There is both oral and e-poster presentations, and also there'll be a very interesting quiz. The abstract submission has been extended by 16 more days. So the last date for submission of your abstract is 31st March 2023. So the submitted abstract, it is important to submit the abstract on the conference website, that is the itsconference.in. So the prelim round of the quiz will be on 27th May. The final round will be on 28th May. The first prize will win rupees 25,000. The second prize will be awarded rupees 15,000, and the third prize rupees 10,000. So there is also the upcoming public awareness program on thyroid, which will be held on Saturday, the 1st April, between 7 p.m. to 8 p.m. It will be telecasted live on Facebook. So for the next session, that is on the 12th of April, so we will be having 2 case discussions and will be chaired by Dr. Rabindranath Mehrotra, sir, from Apollo Hospitals, Hyderabad, and will be moderated by Dr. Uday Phadke, sir. And the case presentations will be by Dr. Shravya. The quiz will be conducted by Dr. Lohit. So I now request Dr. Sarita Bajaj ma'am and Dr. Pramila Kalra ma'am to give the concluding remarks.
Thank you, Gandhi. I think everybody will agree that this has been a fascinating discussion, a panel discussion, as well as the lecture that we've just heard from Dr. M.J. Paul. We had Dr. Vikrant Ghatnati chairing the session. Rajat, I think you've been a brilliant moderator. The questions were, very apt, directed absolutely correctly. And the answers, of course, given by our brilliant panelists, Dr. Ameya Joshi, Dr. Gaurav Malhotra, and Dr. Ritesh Agarwal. So I think what has come out from the discussion is that a team approach. I think that's what they have tried to emphasize. If you're not doing the ultrasound yourself, I know a lot of people are doing the ultrasounds themselves and are doing it very well. They're well trained. They're able to make some definitive diagnosis. Then, of course, you go in for the FNAC. Then again, you have variable diagnosis from the pathologists. So if you have a team who sits down, like Ritesh said, I think then it makes the diagnosis much easier. You've all shared your experiences, I think, and that is what has counted the most. And thank you, Ritesh, for suggesting this. I think once we had one of the ITS awareness programs, and you specifically suggested. So I'm happy I agreed to that immediately. And I said that we will include this thyroid carcinoma, the topic on differential thyroid carcinoma. And the panel discussion has been on the team approach. So thank you, Ritesh, for suggesting, taking it forward, and having excellent moderators along with you. And of course, as well as the panelists. I think the whole credit goes to you over here. Thank you. Thank you so much. Then I think, Srinath, I think this is one of the best quiz we've had so far. And you've explained everything very nice. Thank you. And thank you for including one question from our journal. I think Pramila is smiling there. She's so happy. That is the idea, so that at least people are aware of thyroid research and practice, which is TRP. That is our journal. So I wish we would have more contribution to that as well. And of course, Dr. M.J. Paul, that was an absolute state-of-the-art talk on medullary carcinoma of the thyroid, which you made extremely interesting with the cases that you have discussed. From the common to the extremely rare, I think that adds a lot of value to any presentation. Thank you. Thank you so much. And Ganvi, most dependable reporter. Thank you, Ganvi, for being there throughout for all the sessions. And of course, it would not be possible without our scientific chair, Dr. Pramila Kalra, the secretary of the Indian Thyroid Society, Dr. Arun Menon, and the treasurer, Dr. Minnie Pillai. And of course, the digital team is also always with us. Thank you, Ashmita. And the team from Medisage, we have Vidhi and Karan. Thank you. Nancy is also here today. Thank you, Mansi. Thank you. Thank you so much. Over to you, Pramila.
Yeah, just ma'am has already talked about thyroid research and practice. Just a request to everyone. Now our journal is coming regularly. So if you have any articles, please submit it to our journal. That is a journal of the Indian Thyroid Society. The website is working. You can just submit it online and the peer review process is very fast. And we are trying to make it a regular issue so that we can get the proper indexing for our journal. So that's our aim. So we should all work towards it, because if we get it indexed in Scopus and later on in PubMed, it will be very nice because it's our journal. So we should make it like that. So please submit your articles concerning thyroid to the ITS journal. If you have any case reports, if you have any full text articles, if you have it with you, or if you are planning to write, please submit it, and we'll be happy to accept. If you want to write any review articles also, you can let us know, and we will be happy to accept that as well in case we find it useful. So please submit your articles to Thyroid Research and Practice.
Your student, isn't she, Bharti?
Yes, ma'am. Bharti and Sagar also, ma'am.
Yeah, congratulations to the winner. I think they always join and they do exceedingly
Yes,
well.
ma'am.
I hope
Yes, ma'am.
that they really have a good experience. And of course, everybody should know that all these clinics go up on the website as well, which Ganvi has told us about. You can always access the whole program if you have missed it in whole or part. So it's all there on the website, thanks to our digital team. Thank you. Congratulations to the winners. Thank you. Thank you very much. Over to you, Ganvi.
Thank you, ma'am. I think we can conclude, ma'am, with your permission.
Thank you.
Yes,
Thank you.
yes.
Good night, everyone. Thank you so much.
Good night, ma'am. Good night.
Good night, everyone.